Hello, everyone. We are so pleased to have you here today. We are here to talk about patient self-care and monitoring. I'm Michelle Capseflo. I'll be monitoring. I am from ustwo, a digital product studio with 5 offices across the globe. I'm from our London office and I head up growth. I'm going to briefly introduce these 3, but then ask them to say a bit more about themselves because their backgrounds are quite rich and I'm not sure I can do them justice. With me, I have Kapil Parakh, MD, and medical lead at Google Fitbit, Alisan Atvur, a principal UX researcher and design thinking catalyst from Novo Nordisk, and Karsten Wehrville, CEO of ustwo and my boss. So just to introduce our topic, and then we can get a bit more into their backgrounds and start the questions. The evolution of technology has put clinical data at our fingertips with smartphones and wearables. It's an opportune and transformative time in this space, and due to the maturing of enabling technologies, the interplay of big data and AI, and patient adoption, it's a thrilling time. But there's also been a lot of transformation in part due to COVID-19. I think, Karsten, you said it really well. The jolt to digital health need to go from an idea to a reality was very much in that event. And it's truly accelerated care solutions out of the hospital and the doctor's office into our homes, creating new opportunities for commercial applications and impact in areas that we'll talk about today, like treatment, diagnosis, in-home care, and value-based care. We'll talk about opportunities and risks of this convergence of clinical care on consumer electronics, the promise and the perils, some might say, and get into it. So you all bring different contexts and experience to this problem. Can you tell me a bit about your professional background and how you arrived here?
Thank you for having me, Shirley. Pleasure to be here. My first time in Copenhagen, so beautiful city, and excited to visit. So my background, I grew up in Zambia, small country in Southern Africa, did medical school there, and then moved to the US for further training, which is way too long, but includes cardiology training as well as a master's of public health and a PhD in epidemiology. I made my way to Google about 8 years ago, and I worked on search, on Google Fit, and now on Fitbit. And I support our partnerships around the world, thinking about interesting ways to use these consumer devices appropriately in health use cases. I see patients 1 day a week, and I'm based out of DC.
Hi, my name is Alisan. I grew up in the United States, but about 8 years ago, I moved over here to Denmark. For the past 15, I've been working in strategic research and strategic design efforts at consultancies, but the past 10 years, specifically in healthcare. And that included hospital groups like the one I'm employed by right now, like Novo Nordisk. And a lot of the work that I'm involved in is borrowing from some of the insights and learnings that I had being taught as a psychotherapist, as well as being educated as an instructional designer and a communications designer. So with all of those being kind of merged together, it is offered, I'm thankful to say, a nice perspective towards how we might face some of the unique opportunities you just described.
Hi, my name is Karsten. I have a Danish name, but I actually grew up in Germany and have been living in the US for the last 20 years. Michelle already mentioned we're a digital product studio, which means that we design and conceive digital health applications, among other things. So we work on both health and fitness apps, but also with more chronic conditions, from diabetes to ostomy care. And so I think we and I myself often find ourselves in roles as translators and as advocates. So we want to be the advocates for users for digital healthcare, because often digital healthcare solutions are created from the database up with a sort of IT mindset without thinking about the patients and the clinicians who will use them. And then we often try to translate science into consumer mindsets and back. And so I'm particularly excited today that we have representatives from both the kind of consumer electronics world as well as the pharma world and the science world.
So just to get started, Kapil, you see clients 1 day a week, which is a brilliant sort of coalescing of your experience and background. You must have patients that bring in Fitbit data to your practice. What is the value of that, and what's your view?
That's a great question. Thank you. So yeah, I see patients 1 day a week in the VA Medical Center in Washington, D.C. So these are veterans who have served in the military. Some of them do have smartwatches and devices. Part of my job is to help them turn that data into something useful. And I have a unique training because I'm a cardiologist, but I also have this background in digital health. So I can do that in a way that many clinicians can't. And I think that's where sort of there's a bit of a gap. So the analogy that I give is, if you show up at the doctor's office with some blood pressure readings, just for the record, blood pressure is a terrible measurement. It goes up and down. If you stress, it's high. If you relax, it's low. But we found ways to make it useful and meaningful. You get trends over time, ideally at the same time, around the same way. There's white coat hypertension, so if you take it to the doctor's office, it's elevated, so you try and do it at home. You do ambulatory blood pressure. We have figured it out. And then, so when you show up at a clinician's office with some blood pressure readings, they look at them and they say, oh, I know what this is. Here's what you do. That lisinopril that you're on, go from 10 to 20. And it takes a 7-second interaction of like a quick scan and a conversation of what you do. You could do the same thing. I can do the same thing with wearable data, where I can say, oh yeah, this is your activity rate. Well, with your hypertension and so on, activity is better for you, and you know what, you're not sleeping so well. Try and get to bed early there. Maybe take a walk before bedtime because that'll help you sleep. 7-second interaction, I can do the same thing. But I have the ability to do that, and I think most clinicians don't have that training and wherewithal to make that happen. In addition, we don't have the systems in place from a process perspective to make that easy, and both from a technology perspective, it's not built into EMR solutions and things like that, as well as from a reimbursement perspective, whereas I could get paid for looking at blood pressure data, I can get reimbursed the same way for looking at wellness data, even though chronic disease and lifestyle are such a critical part of the diseases that we see as a cardiologist, as an internist. The reimbursement rates for these are different, and it's just not incorporated into our systems of care the same way.
I find this extremely interesting and relevant because I think, as you said, you have a certain expertise to be able to translate data or translate this type of information in a way that is extremely meaningful to a better treatment. And it reminds me of how I guess, a bigger question of how might we actually enable more clinicians to be able to be set up for an even more successful treatment because they can either interpret this information differently or it's packaged and shared with them in a way that is actually fitting into the way that they practice, but then also coloring the way in which they consider the options that come next. If both the input of that information as well as the way in which they can react are made even easier and more approachable, then that naturally gives the world more people with your kind of specialization. And that may not be a simple task, but a hugely important one.
Yeah, no, for sure. It's something I'm passionate about and I've been working on. So for example, some of the things that we've done is, Carson, you were saying you had worked on Wear OS at Google before. That was my prior team. And one of the things we did was, when we were redesigning Google Fit, the question was, how can we make this useful to users, but at the same time keep in mind the clinical evidence, the kind of, and so I actually helped lead partnerships with the World Health Organization and the American Heart Association to turn their guidelines into metrics that are incorporated into the experience. And one of the things was we then did a press tour afterwards and explained how we'd incorporate their metrics. It was the first time that the WHO had allowed a logo to be used in a consumer app, and we pioneered that. But fast forward 3 or 4 years, now when you see reviews of new devices out, reporters talk about this helps you follow the guidelines. And the guidelines are something that are scientific, that are recommended by these public health bodies, that clinicians also talk to their patients about, right? So like you're bringing the consumer technology world, as it were, closer. On the provider education front, I helped launch a page on Fitbit directed to healthcare providers. And we did this in collaboration with the American Heart Association and the American Academy of Sleep Medicine, articulating how the metrics that Fitbit tracks align with those guidelines. Again, so you can translate what you see on that. Fitbit has a wellness report that summarizes this information, but then can you translate that into sort of your practice? So I think these are sort of small steps in that direction. Each one was a lot of work, but they're small steps in that direction, and we have a lot more to go.
I think the challenge is that as you know better than I, Fitbit or an Apple Watch are not medical devices. They are treated differently from a regulatory perspective. And yet the information that comes from these devices has clinical relevance, and it's increasingly playing a role. And so maybe a couple of stories to illustrate this further. One of my favorite persons in the world is my mother-in-law. And my wife and I wanted to get her an Apple Watch because of, she's getting up there in age and she has orthopedic issues, and we were worried about fall detection or excited about the possibility of fall detection. Of course, she didn't listen to us. And then she talked to a neighbor, and the neighbor said, you should get an Apple Watch. I got one. Of course, she listened to her. And then she got an Apple Watch. And then what happened is a little bit later, the Apple Watch told her that she had AFib, which is basically, you can explain this again better than I, but I think a common form of irregular heart rhythm. And it's a serious condition. And there's the risk of a stroke. It brought her to a cardiologist, and he said, well, this is serious, but it's treatable, and here's what we can do about it. So it actually provided a diagnostic function, right? And then on the other end of the spectrum, I don't know if this story made it to Denmark, but last week the New York Times reported that some of the call centers, the emergency call centers in the US in skiing areas, are completely overloaded with calls, with 911 calls, because Apple brought out a detection feature, a crash detection feature in November. And now it turns out that when people go on the slope and they're twisting and turning, it unleashes these calls. And in theory, you could stop it, but I guess people having too much fun going down the slope. And so in that case, it's a false positive, it's a false signal, and the call center basically is overloaded. And that, where the first example might save a life, this could actually be costing lives because people cannot send first responders out. So I think what I'm interested in is sort of like how much of this is signal, how much of this is noise, and how much of the noise are we willing to tolerate?
Yeah, that's a great point. The way I think of it is sort of, I have both a public health lens as well as a clinician's lens. And I'll speak to the Fitbit side of the house. But in terms of, if you look at the way you design these solutions, they have to be designed with the system in mind, sort of to, Alisan, the way you work. If you just make it sort of in isolation without thinking of the system that it's going to be deployed in, then you run the risk of challenges like the ones you described. So for atrial fibrillation, which as a cardiologist, I take care of many patients with atrial fibrillation, there's a certain population that goes undiagnosed. And so being able to bring those to the light of clinicians is useful. Now, neither Fitbit nor Apple nor Withing, Samsung, any of the devices that can detect atrial fibrillation, in the United States, they fall under a regulatory framework that is actually under detection, not diagnosis. So as a clinician, I can't prescribe a medication based on this reading. I have to actually do a medical grade test and confirm the diagnosis before making that sort of prescription. But instead of providing this test to thousands of people, I can now focus on the few that might be at increased risk based on this. So it is useful, but you sort of have to think through the ways that it's incorporated in the system. I'll talk about another example from our work. So this is direct to consumer, like we sort of, with some thoughtfulness on, listen, atrial fibrillation is like 1% of the population. So if your algorithm is 95% accurate, that's 4% of the population. When if you do nothing, you're 99% accurate. So you have to have an incredibly high accuracy rate. That's some of the work that we've done. So for example, Fitbit has best-in-class sleep detection, and so you detect this when there's no motion in sleep, and so you're much more likely to get a correct thing. So that's the AFib part of the house. Another sort of set of work that we're doing is around building partnerships with health systems, with pharma companies and others, to incorporate these devices in thoughtful ways into care pathways. So one example is in India and in the UK, we're collaborating with a partner called Connected Life. And they provide Fitbit devices to patients who are recovering from a heart procedure or heart attack or things like that. And they provide doctors a dashboard that summarizes this information. But the way they do their alerting is that the doctor doesn't get every alert. The first sort of line of defense, as it were, is a call center. And the call center calls the patient up and says, what's going on? If the patient says, oh, I didn't wear my device, they're like, well, please wear it or charge it or do. If the next one is like, oh, I'm kind of a little unsure about what to do with my medications, okay, we'll get the nurse to call you back and figure out what you do. And then if it's truly like I'm having chest pain, then you call the doctor.
That's straight to the heart of the point that you were making, Alisan, around systems and how vital it is that they're well integrated. We've also talked about sort of efficacy and detection versus diagnoses. Can you tell me a bit more about, putting that clinical data into patients' hands in the context of chronic conditions that you're researching?
Sure, I can at least speak to it from beyond just, say, individual experiences, but what I'm consistently hearing across some of our peers and friends and across the pharmaceutical industry. And I so desperately wish that we could say we only need one intervention or one touch point and it would solve it. We just need this dashboard or this device or this thing and then it would overcome it. But I'm not certain that's realistic. And as a result of it, it is harder, more systemic work. So in that sense, the way at least I've found myself framing it has been like, how do we translate from one body of information and evidence to another when the person who's receiving it, whether that person's a clinician, a doctor, a caregiver, someone who is a part of an emergency response program, can use it. Because if that translational effort isn't put in, visually, linguistically, in terms of what's meaningful to them, I sense we may not see the results that we want. But that is quite an effort. And it is something that, again, I wish it could only be one person or one thing that could do it all, but it requires a collaboration across a series of partners that isn't perhaps as historically familiar to a variety of industries. So I'm wondering if that's going to be what we increasingly see emerge more and more. What might be called a partnership actually becomes a much more interesting and complex relationship of interplay and interfacing, and an interface that may be introducing a brand new industry in the process or a new intermediate between those two in the process.
I'm hearing the word translation a lot, and Carsten, you were the first person to say it, although it's coming up time and time again in different contexts. Can you tell me a bit more about how ustwo translates the world between science and the patient, and how you see that relating to the systemic interfaces that we need?
Yeah, I think in a lot of our work, the starting point is something that comes out of science, that comes out of R&D, out of the lab. So a drug is proven to be effective, a molecule or treatment area. And then the question is, how do you bring that to the patients, how to actually introduce change and have good patient outcomes? And so we come at it more from the world of understanding the life of that patient from a subjective perspective. And they often think about their condition quite differently than the physician or the payer. And so maybe an example, we worked on migraine, on a very common condition in our migraine apps. Patients play a critical role in reporting their pain. Migraine logs or journaling has been quite common for many years, and we're now bringing this into the digital realm. So, I mean, the initial premise was the patient participates in the log, in the journaling, and then we combine that information with the drug to make the drug more personalized, more effective. But then, Kapil, you alluded to this, the reimbursement logic dominated, and in the end, it wasn't just about how does the patient feel. It was much more about the length and the intensity of the pain, because that's what triggers the drug and what's important for the reimbursement. So we found that for the patients, the most important question was not how much pain am I in, but how do I get my life back? Because a migraine attack is hanging over you like a cloud. You don't know when to go on a date. You don't know when to go on a job interview. So what they cared for more than anything else is to know, when is this going to happen? But the drug regimen, the reimbursement was all about what's the level of pain in a sort of functional way. So I think translation is often about bringing the scientific and reimbursement logic together with the subjective experience of the patients.
I find that such an interesting and relevant example because as you're describing it, I hear these different types of results that a person may want from his or her lived experience with this condition versus, say, some of the ones that may be more important to an insurance provider versus, say, some of the ones that may be more defined for a clinician. All of them are important results. But if we only focus on one and assume, well, that will actually lead to success for the others, I would suspect that we may not have the uptake that we want, the success that we want, and some of them are going to be disappointed. But that effort is super important.
Alisan, you talked about new partnership models, and I'm wondering, thinking about the fact that healthcare transformation is a bit behind some industries like banking, are there sort of new ways of working that need to be adopted by healthcare or pharmaceutical companies to deliver on these patient solutions?
I think there's a lot of development of new ways of connecting that I don't, for example, say, oh, there's a precise model or an idea for an infrastructure. But I do think because there's an industry that has been around and been very successful for a long period of time, and for a period of time did not exist in the world of digital, that will evolve because of that. We were talking about other industries earlier that were in similar situations, such as automotive industries, a variety of groups where there may have been a tradition of one specific product or solution being the thing, and then suddenly it has to coexist. And coexisting, I think, involves understanding, well, how am I going to interface with another group? And sometimes it will be as simple as just sort of saying, hey, we good? We're going to start this, and then it works. Other times it will be more nuanced. I think one of the things that's worth considering is going back to what you were saying. What are the kind of outcomes that we're trying to achieve when we partner together? Are we achieving exclusively medical outcomes? Is it medical and meaningful? Hopefully it's both. Are there more outcomes that have to be considered in terms of other players like insurance providers, like healthcare systems? That makes something just require more than just one perspective of just you and I, but instead us in the context of everyone else that we're playing with. And I'm interested to see where we see more experiments of that model across the globe, because every country will have its own regulatory demands and needs for what a partnership is allowed. I wonder if we're going to see more smaller ones within countries or regions.
Kapil, I'd like to ask you, from a physician's perspective, what level of patient self-care and monitoring is positive and where does it go too far? And then Karsten, kind of as a follow-on to that, from a design perspective, how do you design solutions that can have a meaningful impact for patients?
I think from a clinician's perspective, the way I tend to tell people, not just about wearables or tracking or things like that, but just the way people consume digital technologies and health information online is, to me, this is a sign that your patient is interested and engaged. And so for most clinicians, one of the hardest challenges we have is to get somebody engaged in their health, to care enough about their disease, to do the things that we tell them to do. And whether it's take your blood pressure medicines or your heart disease medicines or test your glucose multiple times a day, whatever it is, you have to care enough to do this. And the fact that you have gone and looked up online, bought yourself a device, tracked some metrics, is a sign that you're invested in your health. Now, you may not be tracking the right things, and that's okay. You may be reading information that's a little suspect. That's actually okay, because what the clinician has the opportunity to do, because the clinician's voice is so important in a patient journey, is to almost take this like martial arts move of take that energy that's going the wrong direction and to redirect it in a way that's meaningful and actually helps the patient. And that does a couple of things. So the first thing is it validates the patient. I see you, I see the effort you're putting in, and I appreciate it. It builds that trust between the clinician and the patient to say that, the patient feels like they're being validated, that they can listen to and follow the advice of the clinician. All too often what happens is we're busy as clinicians, and you come in with all this stuff, and I have an agenda in my head. I actually write about some of this in a book. But I have an agenda in my head. I got to get through, look, I got to go through your diabetes stuff, I got to go your heart disease stuff, make sure and check your blood pressure, blah, blah, blah. And they're like, oh, I looked up this stuff online, or here's what my Fitbit says. That does not fit with what I need to get done. I have 7 minutes or 8 minutes that I have, and now you're wasting my time. So all right, that's fine, but we really got to the important stuff, right? In that scenario, the patient is dismissed. They're sort of a little suspicious of you because look, I did all this work. You're not even interested. Do you even care about me? And now I'm supposed to listen to what you have to say to me. And it starts to, combative is the wrong word, but it becomes less synergistic and more antagonistic unnecessarily. So I think whatever the patient comes in with, it's up to us, and we don't have that training, most doctors don't, to take that and help them make the most of it in their specific situation, because we know better what they can use in that situation, and it's not going to be the same for everybody. But that kind of nuance is really hard to bring out.
I was just reflecting on, as you were describing this, the part of me that was trained as a therapist starts listening to this as a relationship. Two people coming into a relationship with two different perspectives, which are totally fair, because that is the perspective that they entered with. Are they shaping the relationship differently because of the things that they're bringing in? If not, is that actually creating a clash and then going, well, I did my job and you didn't listen to me, and that leads to that. So I think that often, for me, brings up the question, how can that relationship either change to be more successful for more groups, because it can't just be more successful for one or the other systematically. And that might involve interventions like we're talking about and tools and systems like that. It may also mean an evolution of the way in which we practice care delivery, which starts to set new examples. But it may not be terribly possible when you only have 7 minutes per person. So also acknowledging the limitations of that. I think all of these kind of have to be considered when the next X is introduced to a treatment solution.
You were asking how to design digital health solutions, right? And I just wanted to pick up on a couple of things that Kapil said. So there's attention, I think there's sustained engagement, and then at the core, the idea of having patient empathy. So I mean, getting people to pay attention to their condition is very difficult. I think what we're excited about in the context of digital health and wearables is that it puts medical data right at our wrists, right? As in the example of my mother-in-law, she had no idea what an AFib was before, and now it's very present. So I think that's exciting to have that present. What's really difficult is sustained engagement. We know this through problems around adherence and many others. To get patients to pay attention to their lives is very difficult. But what ustwo is both a digital product company, we're also a gaming publisher, and so we're sometimes applying game design principles, not in a sort of shallow badges and trophies type of way, but when you design a game, the first question is, where's the fun? Now, there isn't a lot of fun about diabetes or chronic kidney disease, but I think you can still ask with the question, what's the emotion that we want to evoke? How does this person feel? How do we want to make this person feel better? And then you back into features and functions and science. And I think if you do that, if you start from the perspective of empathy and looking for emotional impact, not just for medical impact, then you can get on a journey where a lot of the things you might talk about in gaming apply here as well, like the idea of progression. You get from one level to another, you make progress. Ultimately, getting to patient outcomes is very challenging. But I think for particularly people with chronic conditions, we need to give them hope. There needs to be a sense of, I'm getting to the next stage. It's not like my life is over, it can only get worse, but no, you can live with this.
And it's an interesting story as you describe these examples, because I think there's also a delicate balance of course, providing some sense of hope and aspiration that things are going to be better. You're going to return to a life with fewer migraines, or it's going to be more manageable. And also simultaneously, and I think this is a delicate balance, often achieved through design, helping you not have to think about it, helping you not have to pay attention to a condition that is hopefully not going to be in your life at a certain point, or is going to feel completely invisible. That interplay, that balance is something that is carefully achieved through a variety of interventions, not giving too much or not giving too little, and at the right time, which seems like a Goldilocks problem, but to some extent it is. Like, if it isn't, we notice it.
Maybe just one more quick example. So we worked many years ago on a cognitive behavioral therapy app called Mood Notes. And what's very different about this versus conventional CBT is that normally, as with many medical conditions, you have to spend a lot of time collecting data upfront. So patients have to fill out forms. They have to provide a lot of information about themselves. And so we, in that context, minimize that information. And then we provided feedback progressively. So the more you told us about yourself, the more we could give you specific feedback rather than overloading you. And as a result, the retention rates that we received with that app was twice the average of conventional CBT apps.
This idea around progressive feedback is so interesting. And I'm also hearing that, in some ways, apps, dashboards, diagnostics can be a tool for personalization, but nothing quite replaces the clinician's role, the physician's role, rather, in personalization. So can you talk a bit about that? How do you marry those two, personalization within, apps or those outputs?
No, I think that's right. If you think about like consumer technology experiences, right? Like they're designed in many ways to be engaging and sort of thoughtful. And so in the example in the NHS where we worked with a group that was trying to provide cardiac rehabilitation to patients, they paired the wearable and dashboard with their cardiac rehab team, mostly consisting of nurses supervised by a cardiologist. What would happen is, so pre-COVID, people would come in 3 times a week to a rehab session and then go back. You can already imagine that coming in 3 times a week to a physical activity and rehabilitation session is hard for many people. So the uptake rates, even though there's great evidence around this, were not super high. COVID hits, you can't do this anymore. So the sort of backup plan was just to deploy, and this is the acceleration that you mentioned around digital in COVID. And so they deployed Fitbits and a dashboard. And now what would happen is the nurses would call the patients every week, sometimes the therapists, et cetera, physical therapists. Hey, how are you doing? I noticed this is what's happening in your steps. This is what's happening. So you could then actually talk to them in ways that were meaningful about their activity levels, not just watch them walk on a treadmill, and so on and so forth. And the result of this personalization, one was the patients are super engaged. They felt when you left the hospital, you were being monitored 24/7. People were rounding on you, people were checking in on you, and you feel abandoned, right? Like my mom, who went through cancer therapy, she finished chemo, radiation, and then when she was like surgery, chemo, radiation, and then when she finished, she felt, she was crying because she was like, I've been let go, and now there's no one to keep checking in on me. So these patients who had their wearable felt very taken care of. As a result, they felt responsible. Their use of medications went up. Their compliance with exercise went up because they felt they were part of this sort of being cared for. And the team could give them personalized advice on, like, you know, you might have arthritis and maybe your goal is 1,000 steps a day. Or you might be a young person with a heart attack who's otherwise perfectly fine and you were running marathons before. You should be running 5Ks by now, right? Like, and it's very different advice, but based on the data and the dashboard from your wearable in the context of that person's life.
I think personalization is such a buzzword, and it's often too difficult to achieve in a technology context. I would rather, much rather have a clinician, a physician, a nurse provide context and personalization. So maybe an example, we worked a lot on hemodialysis, which has enormous promise because so many people that live in rural areas have to drive for hours to get to dialysis clinic, and then dialysis takes many hours, and so on and so forth. It's also challenging because it's a procedure, and a lot of patients feel overwhelmed by it. And so, you know, they might have questions like, this looks red, is this an infection or not? You could build a complex algorithm that scans the picture and tries to analyze whether it's infection or not. I mean, I would much rather have the patient text a nurse and say, what does it look like? Or the doctor and say, what do you think? But even those like immediate protocols, right? Is it even okay to text the clinician directly? In many countries it isn't. So I think it's much better for you to provide context and personalization than for an algorithm.
To add on to these things, which are really thoughtful points, I can't help but think of this in terms of say, if we were to imagine treatment, especially treatment for a chronic disease, which may occur over time as a service experience, like a service that appears over time over touch points, then one of the natural things to consider in this case, if treating or designing it like a service experience, is the actors or the people involved, and of course the end users there. But then when we start to talk about personalization, an actor that I sense could get even more attention is the clinician. And there's two specific things that come to mind when I think about the clinician being involved. One is that there are very different clinician styles, and which is to say that what is going to completely work for one doctor may feel completely foreign to another. And maybe it should, because that doctor has built up a patient body that really connects with that style. So one personalization method may not rule them all. The second comes in clinical circumstances. 7 minutes is a very different interaction than other interactions that may be a lengthier because of either the ability to have a longer appointment with someone or a person's patient workload. I think both of those two will color, hopefully, when done well, positively, whatever personalization occurs. But ultimately, the person who's the most personal in terms of connecting, I would imagine, with a person often is the clinician. So that relationship, I think, is the thing that is catered to, or could be catered to even better, even if it's not adding burden to any person's life, neither to the clinician or to the patient, but doing so in a way that just makes that 7 minutes the best possible 7 minutes it ever could have been.
I would be remiss not to mention that, you know, we're in the middle of a epidemic is a wrong word, but this sort of clinician burnout, and it's a reflection. I have so many thoughts about this. I'm going to try and summarize them. It's a reflection of there's a nice article in the New York Times about this. It's a reflection of how the systems have failed clinicians and not how clinicians are inherently flawed and failing. And I think it's a very important distinction because we've actually seen physicians commit suicide, get into real mental health problems, because burnout implies that something's wrong with you. Whereas what's really happening is that you are being made to work, you know, in extreme conditions that are just create unfathomable challenges. And it's everything from clunky electronic medical record technology that take up enormous amounts of data entry time to the workload that's put on clinicians, right? So as a clinician, you are not only responsible for delivering care, but you're responsible now for many quality metrics. every intervention seems to want to go through a clinician. Hey, we need more seatbelts on people, so your pediatrician should talk to you about seatbelts. We should get people to stop smoking, let your clinician talk to them about this. And the list keeps adding on. Hey, I've got a new digital gizmo. Let the doctor talk to them. Show the doctor the data, they'll figure it out. And like the list of things that doctors are being required to do just keeps getting longer and longer. The reimbursement rates over time have fallen. The workloads, so your patient visit time is getting shorter because you're trying to squeeze out more revenue for that time. And it's really leading to this seismic shift in, clinicians are human. They don't want to do this anymore. And people are leaving the medical field for other things. People are less likely to enter the medical field and so on and so forth. And so I think as we think of new ways of working, new solutions, I mean, this is what I like about the program that I mentioned before, where there's tiered approach so that the clinician's getting just the data they need so they can practice at the top of their license and really just action on the things that they really care about and they're best suited to deal with. And so I do think it's really important to be thoughtful about how you incorporate clinicians in your solutions.
I'm so glad you brought that up because I was reading just yesterday the WHO is predicting an 18 million person shortage of doctors and nurses by 2030. It's massive, and there's other challenges facing the industry as well in terms of cost increases and information overflow, as you mentioned. So what are the promises of the digitally enabled patient for physicians? What is your great hope?
Yeah, that's a great question. My hope for this is, and I'll sort of close with going back to my book. What I wrote about is how do you take information that's online and make it part of a visit in a collaborative way, right? Like, so most people just show up at the doctor's office. If you show up at a lawyer's office and you know you're getting charged by the minute, you go in prepared. You have a list of questions, you know exactly what you want. But if you're going to the spa, you say, oh, you're going to take care of me, I'm just going to show up. People go to the doctor to get taken care of, and they should go prepared. And they should know how doctors think, what they're looking for, what a doctor's agenda is. And if they want to create space for their problems, their questions, they can be prepared for it. And then there are tools that we can sort of provide them with so that when they show up, they're empowered. The healthcare is one of those few places where if you're buying a house, if you're going to college, if you're going on vacation, you're much more empowered by the internet, by digital data of so many types. But in healthcare, it's quite the opposite. You feel confused and you show up even less empowered than you were before. And I think if we can find a way to make that shift, whether it's through digital tools or other, that could be incredibly powerful.
I mean, for me, it's simply that the promise of digital health is that patients are more informed, that they feel more agency over their lives, that they feel they can affect their condition, and then ultimately that will improve their condition so we have tangible, objective patient outcomes.
I didn't quite mean to close this off, but give us an answer and what you think, and then I have a few follow-up questions.
I wish I could give you a specific answer. I'm just agreeing with the intentions and the perspectives here because there's so many things that have been mentioned to make a reality like this happen. And it goes back to a point I mentioned earlier. I wish a single app, or I wish a single instructional approach could achieve all of the outcomes we're talking about. And in reality, I'm sensing it's a lot of things that are going to be working in concert. Understanding a relationship better, being able to work with tools better, being able to translate information in the way that's needed at the time that's needed so that it's respecting that time. All of those things are going to be an entire experience achieved by a series of touch points, many of which I think will be digital. My personal hope is that we actually start to see the outcomes that we know are possible when we have that experience. That's both on a medical side, but more importantly for the human in me, the meaningful side of what people are trying to do with their lived experiences.
We talked about new care delivery and the empowered patient and recognizing the need for patient empathy, but there's also changes that need to happen within large organizations. I mean, Carsten, we work a lot with organizational transformation at ustwo, our book on the table and at the back, if you'd like to pick one up. Make, Learn, Change is about integrating agile delivery practices to make meaningful, lasting change in how we bring products and services to market. what are some of the ways, what are some of the new, perhaps, ways of working that organizations need to adopt to deliver these new products and services?
We could talk about this for definitely more hours, but I think probably the biggest misunderstanding, I would say, in healthcare and big pharma of something like agile is that it just means fast. The whole point isn't to be faster. People are already working hard. I think the point is to work in a more iterative fashion, in a more collaborative fashion, in a more cross-functional fashion. Often in big healthcare companies, it's not really clear who owns technology. I mean, it's not necessarily the technology team. So we often need to produce solutions that can work across conditions, across brands. So it's just a different way of working than maybe the more industrialized way of working where people have a very distinct set of responsibilities.
I can add a different build on that perspective. So in a prior life, I worked at Hopkins, and I was the head of a heart failure program. And I had the opportunity to go to IDEO and learn about design thinking. I was just blown away, and this was over a decade ago, and I've sort of been hooked ever since. I'm not a designer or a thinker, but I've tried to introduce that to people, and I've done sort of sessions with cardiologists, and I've done it at the WHO, and just try to, I teach a class on it now at Georgetown. One of the things, like somebody stood up and like, look, all these sticky notes are fine, but they're not going to change medicine like that. Our systems are so flawed. Like, what do you think this can do, right? Like, this is just noise. And my response to them was, you're absolutely right. Our systems are so flawed. Our healthcare system is so flawed that we need every tool we have to fix it. Why would you not want, if it's not like what you're doing is working? So why would you not want a new way of thinking, a new way of approaching it?
I was getting excited because this is in connection to I'll get academic for just a second, then I'll stop. There's a professor named Richard Buchanan who talks about the orders of design and how we have historically made physical and digital things, physical and visual things, posters, toasters, then we entered a domain of making services and experiences, but there is a fourth domain of design. Redesigning systems, designing with the perspective that the players involved, the end users, the clinicians, the policymakers, all are people that must be considered. And without considering that system, we're playing with a part. And I wonder how to both, in the process, imagine better services and experiences that also enable system change, or vice versa, because I don't think we're going to be able to exist in the exact same system and achieve the results that we're hoping for.
Brilliant. Thank you so much for joining us today. If you would like to pick up a copy of our book, Make, Learn, Change, it's on the back table. Searching for Health is the name of Kapil's book. And we're just really pleased to have you all. Please reach out, learn more about us too, stick around, have another cup of coffee. And thank you so much to Kapil, Alisan, and Karsten as well.
Thank you. Thanks, everybody.